Welcome to the podcast, Not Your Doc Anymore, where we address the issues essential for your health and provide information to help you become your best advocate. We encourage empowerment through education. I cannot emphasize enough the power of clinicians who understand clinical practice and are actually seeing patients on a regular basis and have had years of experience. Here to address the topic of low back pain, especially in pregnancy, is physical therapist Cheryl Farnsworth. Welcome.
Thank you.
So
I'm
great
excited
to
to
have
be
you.
here. Thank you.
Excellent. I'm going to tell just a little bit about Cheryl. She graduated from the University of Utah with her master's degree in physical therapy in 1998 and has been practicing in the outpatient orthopedic setting since that time. Early on, she saw a need to help pregnant women with their back pain, so she developed a program diagnosed specifically for their needs. She has been very successful with this and has treated thousands of pregnant women with back pain at all stages of their pregnancy. She collaborates with many obstetricians in the Valley, assisting them and their patients having pain during this critical time in their lives. She started her own clinic called Cutting Edge Physical Therapy in 2008, so she could specialize in SI joint and pelvis and low back pain. She also treats patients with chronic pelvic pain. Cheryl takes a holistic approach to treating the body. She has many modalities to assist in healing body, mind, and spirit, finding the underlying cause of the problem or pain instead of just treating symptoms. Her background is in manual therapy with hands-on treatment, including myofascial release, joint mobilizations, functional dry needling, and various forms of energy work, resetting the nervous and musculoskeletal system to restore balance and wholeness to the body. Assisting people in returning to full function and activity is one of her passions. She can also be found hiking the many trails in the valley, as well as enjoying gardening, rock hounding, and adores her two young grandchildren. Cheryl, I just have to say this on a personal note. I started my practice in 2000, really treating a lot of chronic pelvic pain patients. And I remember suffering for about 2 years because I knew theoretically that we needed to have this holistic approach, not just an OBGYN, but also involving urology, involving gastroenterology, involving physical therapy. And I remember for the first couple of years sending patients to physical therapists, and these were complex patients with chronic pelvic pain. And I would send them to physical therapists, and these physical therapists would call me on the phone and say, "What do you want me to do?" And I would say, "You're the physical therapist. Do what you do for patients with chronic pelvic pain." So it was incredibly frustrating for those first couple of years. But then somehow, miraculously, I found you. And it really changed the way that we were able to treat these patients with chronic pelvic pain. And it really just stoked an amazing collaborative treatment of patients with chronic pelvic pain. So I have to thank you personally for how much you've done for these patients and how much you've done for me and really being able to provide such wonderful care.
Thank you. I remember exactly what it was how we met. I was seeing a patient, I believe a pregnant woman, and you were her doctor. And I just asked her, can I call him? Because I was really trying to meet more people and providers and just so I could help more people. And she said, oh, yeah. And I called you and you said, come on up and talk to me. And I was up there the next day and you spent your whole lunch hour sitting there talking to me, you and Howard, and you recruited me to work with these pelvic pain patients. But it's been awesome. It's been one of the coolest
Yeah.
experiences because there's so many people in pain and they
Yeah.
need help and they're caught. So you're doing such an amazing, wonderful service You've done for so many years helping all these patients, and they are very complex. So it
Yeah.
does take a team, and it's been a really awesome experience. So thank you for bringing me in.
Wow. Well, that's really sweet. Thank you. All right, let's cover the first topic, which is low back pain in pregnancy. I used to always quote patients that the prevalence of low back pain in pregnancy is about 50 to 70%. So we're talking about almost the majority. And this doesn't have to be a 38-year-old who's dealing with low back pain in pregnancy. It can be a young 18-year-old or even somebody in their mid 20s. So let's talk about how you approach this patient. And because I would actually say almost the majority of patients, I would say you have to see Cheryl Farnsworth in order to get some relief and to really set your low back pain history correct so you don't really have a lifetime of low back pain that sometimes starts in pregnancy. So let's talk about how you deal. How are these patients presenting to you? Let's walk us through a little bit of an evaluation.
Okay. First of all, when they come in with this back pain, we really want to know where the pain is coming from and why. Now, pregnancy has an awesome reason for back pain because the relaxin hormones loosen all the ligaments and their pelvis, because that's the main stability of their pelvis is ligaments. So it gets really loose and it's so easy and for it to rotate and get stuck in the wrong position. So with that, they could have pubic symphysis pain. So pain right in the front of their groin. They can also have back pain, butt pain, leg pain, sciatica. They can have so many different symptoms with this. We want to be able to sit down with them and ask them questions. Did it just start with pregnancy? Did it start? Have you had it before? So if it's different when they've had pain before and now they're in their pregnancy. We've got to look at them a little bit differently because there's most likely another underlying cause of the problem. And now the pregnancy comes and the relaxin hormones loosen everything. And now they've got more problems. Now we have to tease it out. Is it same back pain that they've had before? Is it a little different? Is it what's going on there? And the more detail I can have with the eval, we really are able to dial in and find out, have they had any previous accidents? Have they had any previous pregnancies? Maybe they had two pregnancies before and they had no pain. And now with this third one, they have pain. And so that's really what we're looking for, is to really try and dial in and figure out where the pain is coming from and why. And because we've got to know exactly what structures we're treating when we're working with them. And oftentimes they can have pain from a couple different sources.
You've worked on this as well, but so many times we think of our joint as like our knee joint, our shoulder joint, but the pelvis is a joint as well. And I think you touched on that. But sometimes that joint right in the middle of your pelvis, right above your pubic bone, at your pubic bone, is a joint. It's called the pubic symphysis. And sometimes that joint separates because of relaxin. And sometimes there's joint pain in your hip. Sometimes it's the joint and the connection between your low back and in your pelvis itself. So let's talk about first the SI joint. That's the sacrum to the ilium. The ilium's a part of the pelvic bones. Let's talk about the SI joint and maybe get a little bit specific about that. What happens? How are you seeing these patients in your office?
Perfect. The SI joint, the spine comes down. There's 5 lumbar vertebrae, there's 5 discs, but the very bottom part of the spine is this crazy little triangle shaped bone called the sacrum. It's actually 5 bones that are fused together, and it's just in a triangle. It's right above the tailbone, which is 3 bones that are fused together. And so the tailbone and the sacrum are connected by way of ligaments, but also then the iliums, which are the big bones out on the side, they join with the sacrum, and those are the sacroiliac joints. And there is some bony congruency with those joints, but the main stability is ligaments. So they don't move a whole bunch, but they actually move every time you lift your leg. Any movement that goes from your upper body to your lower body or your lower body to your upper body has to go through the SI joints and pelvis.
Okay.
It's just, that's normal movement. And then the two iliums come together in the front of the pubic symphysis. And again, there is a little disc in the middle there, but their main stability is ligaments as well. So with the relaxin hormones, it's loosening all the ligaments, it's loosening it over the whole body, but the main stability of the pelvis and SI joints is ligaments. So they can just get moving a little bit too much, even in sleep. If somebody, there's oftentimes pain with rolling over in bed, getting up out of bed. Those things are, you relax at night and then things can just go out of alignment.
How are you assessing whether it's out of alignment?
I'll usually have them stand. I start at their feet and go up because I want to also look at them biomechanically. If they have really big pronation at their feet, if their feet roll in, I'll look because that can actually affect all the way up the legs to the hips and pelvis and can contribute to it being out of alignment. But then I'm going to come up. So I'll look along the legs, come up and look at the height of the iliums, and then also at these bony structures in the back of in the back that are called the PSISs. They're just where it's right by the SI joints. And you can, if you have,
Could you
you
give
see
me
people with,
can you give me
but
the whole name for that? Can you give me the whole name for the PSIS so we understand
yeah,
that?
posterior
Because I think we have people who are listeners who are maybe
Mhm.
patients, and I think we have listeners who are clinicians. So let's give me a whole.
Yeah. So I go right to the posterior superior iliac spine. So
Okay.
it's just as the pelvis comes back, it, if you've ever heard of people say, I have these dimples, or I've heard, which is crazy to me, that people say these back mice, which I had never heard that before, but they're oftentimes that they're right over, you have these little bursas that are right over those posterior superior iliac spines and they can get inflamed. So I was shocked when I heard back mice. It was like,
Wow.
wow, yeah. But so I'm assessing there, and then I'll have them lift a leg and see how the movement is because when you lift a leg, in order to clear the hip, the ilium has to move posterior and inferior. And so I'm watching them from behind and seeing what the movement is. And oftentimes there's really lack of movement. They may have pain with
Interesting.
that. Yeah, that can reproduce their pain a lot. And just if it's not moving correctly, then they can even get some hip impingement in the front. So
Okay.
we'll assess that. Once I get them, I want to look at the rest of their spine as well and see how that's moving because if you've got hypomobility or lack of movement in the spine, that can also put a lot of extra stress on the SI joints. And
Hmm.
then once we get them down, that's all standing. And then we get them down on the table, then there's other tests that I can do. I'll do a long set test to where they're bridging and straightening their legs. And I'm down at their feet looking at the medial malleolus, which is the inside ankle bones, and checking their leg lengths. And oftentimes when there's a malalignment at the pelvis, one leg will be longer than the other one. And it doesn't mean that the bony alignment, bony structures are like you really got one leg shorter than the other one, but it can be a functional leg length discrepancy. You can have a true leg length discrepancy as well as a functional one, but oftentimes we're dealing with a functional leg length discrepancy. And
Describe
then,
what that means. Describe what a functional leg length discrepancy means.
okay, that's awesome question. So after I have them lay down and have them bridge and straighten their legs, I do that just to realign their pelvis. Because if they just climbed up on the table and they're laying down, they may be all over the place. So I'm looking there. And if I'm seeing one leg longer than the other one, I'm going to assist them in setting up. And what we'll see, if they have a true leg length discrepancy, the legs should stay the same. Like one leg will stay, the shorter one will stay short, and the longer one will stay long. And they'll set up, and you've got the same leg length discrepancy, and they'll lay back down and have the same leg length discrepancy. If I see that, that's going to indicate more that they they may have probably have a true leg length discrepancy where a bone, what the leg, one leg is actually longer than the other one.
Sure.
If when they have them set up, the legs reverse and the shorter leg becomes the longer leg and then goes back down. It goes back to that position, the shorter position when it was they lay back down. That's telling me that the SI joint, they're caught. So it's not moving correctly. And so that's going to give that change in their leg lengths to where I'm like, okay, now we've got some dysfunction back at the SI joints.
That totally makes sense. So assessing leg length discrepancy is a big deal. So how do
Yeah.
we let's talk a little bit how do we get out of that position? How often are you actually doing x-rays of the pelvis to do that?
I'm never doing them. We now can order x-rays, but your x-rays are not going to be a really good indicator of a lot of that because the movements of the joints are not really huge. So if on x-ray you may see a little bit of discrepancy with the pubic symphysis being off a little bit, but it's more clinically what the clinical findings are and presentations that we're
Great.
going to find, yeah, to diagnose that.
Yeah. So to reassure a pregnant patient or pregnant listener, if they have concerns like I'm going to go there and they're going to do an x-ray and it's going to potentially harm my baby, know that this is more of a functional assessment. Is a
Right.
skilled clinician looking at the findings associated with on physical exam. So it's a wonderful thing. Okay, so let's talk a little bit. Can we provide some relief? And maybe is this the largest number? I mean, of the 50 to 70% with low back pain, is this where we're hitting most of the time at the SI joint? What would you say?
I would say absolutely yes, especially I've been doing this for over 27 years and I'm always really open to looking at everything because when they come in, I don't know for sure where their
Sure.
pain is coming from. So I've got to look at their lumbar spine. Do they have any herniated discs or any disc issues? Do they have any facet problems? With pregnancy, the belly gets bigger. There's no other time in a pregnant woman's life that their body mass is going to change so rapidly, both ways, getting bigger. And that can put increased stress on the lower back, trying to counteract the weight of the belly out front. So it actually makes them tend to lean back more, which can jam the facet joints down on each other. And so I look there, but it oftentimes what I'm looking for is just to try and differentiate it, tease things out. I would say one of the biggest indicators of that it's SI joints is that they have pain with movement and rolling over in bed, getting up out of bed, and getting in and out of their car. That's a big indicator for me with SI joints. If they have anything more like a disc injury, I don't even remember the last time I've seen a disc injury in a pregnant woman.
Hmm,
I really don't remember. And I see hundreds of them a
interesting.
year.
Yeah.
Yeah. And the facet joints, I don't find that they're a really huge source of pain. I would say most of the time, like in my, from what I'm finding is like 99% or more is the SI joint and pubic symphysis.
Talk to me about the facet joints. Maybe I'm not understanding what those are. Is that the joints in between the discs?
Yeah, each vertebrae in the back. So you've got the vertebrae and then you've got the discs or kind of spacers in between. But each vertebrae connects up with the one above and the one below on each side. So that's actually where we get the movement from in our spine is actually the facet joints. And they have cartilage on the surface of them, just like in our knee or our shoulder. There's usually 7 layers of cartilage that can wear down and we can wear through those and we can have arthritis. So with the weight of the pregnancy, the belly going forward, the leaning back can jam those joints down on each other a little bit more.
Okay.
But I think that's probably a secondary problem to their primary SI joint.
Yeah.
Yeah.
I've definitely seen you reset some facet joints on patients in the past. It's actually
Mhm.
an awesome thing to see.
Yeah, it's pretty fun. And it's actually so much easier than anybody knows. And it's actually really easy to reset the SI joint and pelvis. And I think it's just absolutely so much fun. You get somebody in with pubic symphysis pain, which they cannot hardly move. They have such severe groin pain and they go to run, get their child or something, and it almost drops them. Some actually will fall from that, from the
Wow.
pain from that.
Wow.
But we just check the alignment. And there's some really simple techniques, some positional release techniques. There's some muscle energy techniques that we use. And we always teach the patient how to realign their own SI joint and pelvis because they need the tools because they're only seeing us like a short period during the week
Yeah.
and they're with themselves the rest of the time. So we really try to educate a lot and give them the tools to be able to help themselves.
Yeah. That's
Yeah.
always was something that I was so impressed by, Cheryl, as you empower the patient to go home and say, okay, we've now realigned your pelvis, but if this happens again, which it does, just because of the relaxin, the hormones of pregnancy will get a little bit more ability for those joints to move, to be able to reset it. You just provide the listener with a little bit of reassurance that this resetting of the joint is not too brutal.
Okay. That's a great question. Because, yeah, we don't manipulate. So I'll just say that right now. We don't manipulate the joints. And what the difference is between a manipulation and what we do is a mobilization is that a manipulation is more a high forced thrust, more of what a chiropractor would do, just the twist and pop. And like in that scenario, your body would not have a chance to react or respond if it didn't feel right because it's too high of a force and it's too quick. The way we really do it is a lot more gentle. And it's just I'll use a block underneath their, say, their ischial tuberosity. If I'm correcting a pubic symphysis, and part of the pubic has gone a little bit subluxed a little posteriorly, then we'll use like a little roller, put it underneath their butt, their ischial tuberosity, their butt bone to bring that up. So they stay there for maybe 5 minutes on that. So it's more of a positional release. It's shockingly simple. And once you know what is going on with it, and definitely we've made it that way to be reproducible at home because that's where life occurs. And so it's just, and then another part is we're using their muscles to pull the pelvis back into alignment. I'll have them put their leg up on my leg and they'll be pushing down, maybe using the hamstring, just nice, easy. And then I will resist their other leg as their hip flexor is pulling up and it can actually twist the pelvis back into alignment. And then we do a couple other little things that are really basic and simple. They're weird, but they change people's pains really fast. I would say
Yeah.
most of the time they get up off the table and they're like, "Oh my gosh, I can actually move." And I got up off the table. So it's really fun and it's rewarding. And I never really have a problem with getting people to buy in to what I'm giving them to do because they saw that it just helped them. It
Yeah.
just got rid of their pain.
For sure.
I never have a problem with buy-in. It's awesome. And
That's so
pregnant
great.
women, especially, I think are there. There's not much they can do. So with their pain, they
No,
really can't
so
take pain
true.
medication, and
Yeah.
they feel like oftentimes they've gotten this gel sentence of these
Mm.
9 months where I can't take an ibuprofen for
Yeah.
2 more months. Duh, I know that would help me. So these are just amazing tools that we can use and then teach the patients to have power over their pain. So it's
That's
really fun.
awesome.
Yeah.
So great. And I want to say that I have been practicing maybe not 27 years, but 25 years. And I quickly send my patients to Cheryl to really get rid of their back pain. And I know for several years you were collecting some data on your outcomes. What are we talking about outcomes as far as improvement in back pain in pregnancy? Are you still collecting data or no?
The data is just an ongoing thing. I would say it's the percentage of helping is so high. I was really trying to keep track of how to tell which way their pelvis was going out. And I couldn't find a rhyme or reason with that. I think it's just, and some people will, oftentimes their pelvis will go out the same way or really similar. That's why I feel really confident in when I can give them things to do. Now, if they come back and it's out the other way, then we have more conversations and then I try to really teach them how. But the success rate is, I would say, really 100%. There's it
That's amazing.
just, yeah, it just, we can help them. And if it keeps going out really a lot, we could also put them, we'll do some strapping in the back. We'll maybe put them in a maternity belt to help really create some stability. So that helps us
Yeah.
along the way too. Yeah.
Those pubic symphysis belts are really quite helpful. Maybe talk a little bit about that. Have you used those?
I find I haven't really used those specifically because once you realign the pelvis, especially pubic symphysis, that's the main thing. And if that is their main problem, it's like a couple minute fix. And then
Wow.
put them in a belt. And then that they some will find the benefits of that kind of belt, but they're oftentimes just a belt around the whole pelvis to compress it once they're in alignment.
Okay.
Yeah, then that's really beneficial as well.
And do you have a name for a belt that it was good for people to use if they're going to be using it, if they're going to listen to this and use some of these techniques? What do you typically use?
I use a couple of different belts. I like to start using some strapping. I usually use some taping.
Okay.
I oftentimes will have patients bring their spouse in and I'll teach them how. There's just a greater trochanteric belt that has a little bit of elasticity because you want that compressive forces on each side of the pelvis. So there's some that are not that expensive. And that's just a greater trochanteric belt. There's, if you're getting into some really of the chronic pain and people are really needing a lot more support there, I can't remember, I can't think of the name right now, but it's got a pad in the back that's a sacral pad that actually it's in the shape of the sacrum. And when you put it on, it puts pressure right on the sacrum. And that is the unlocked position of the sacrum is when it tips backwards at the top. So when you put pressure on it like that with that pad, then that will actually lock in the sacrum and it's pretty amazing. Yeah.
That's awesome.
Yeah.
So great. Okay, let's turn maybe. So let's see, we've covered some SI joint pain in pregnancy. Maybe let's just take it outside of pregnancy for a second. Are there different methods, and why do you think it's critical to deal with this while they're pregnant? And what happens from the time of pregnancy to the postpartum period that's essential to do? And then what are the that new moms are dealing with in
Awesome
regards to
question.
the insult on the back?
That's a great question. So I'll have to tell you a little story. I've had patients, and this is more than one, come to me like 20 or 30 years after they've had babies. And so we're talking, they're in their 40s and 50s, and they've had back pain since their pregnancy.
Oh,
And shocking that they've gone
oh,
on
so
that long.
sad.
Yeah, it's so horrible. And they can identify, yeah, no, it started with this pregnancy and it's just never really gone away. And now you fast forward 20 or 30 years, that malalignment that could have been caught and fixed during their pregnancy or postpartum has now got 20, 30 years of not being aligned. So that's going to put extra stress and pressure on other structures. So now they're probably dealing with a disc herniation or two, just so many other issues. Their muscles have been imbalanced and spasmed for that long.
For sure.
And yeah, so then it's way more difficult. It's a lot more difficult to get under control. It's still fixable, but it just takes so much more time and so much more work. And when we know these things happen during pregnancy, so, if it, I think a lot of times what I found, and you've probably found this as well, that a lot of pregnant women, they just expect that there's going to be pain. And they may not even
Mm.
tell you or their provider that they have it until it gets really horrible. And then till they can't move or they can't sleep. And now they're calling on the phone going, I'm dying. And so I would definitely highly recommend that. It is common during pregnancy for women having back pain, but really talk to your providers about this. This is something that can be fixed so easily, and the earlier we can catch it, the better, because we're also setting you up for potentially much easier delivery. Because if your pelvis is out of alignment and you go in to deliver that baby and you've got the bones aren't lined up, and so I've had people, or I found that people have had problems having in labor and delivery. So I think it sets you up for a much
Just
easier
because of
delivery.
pains.
Yep, just because of pain, and even with the structures being off. The body
Hmm.
is a protective mechanism. So if it's in jeopardy of damaging itself or being injured, it can sometimes stop a process and from happening. There still can be things happen. I think the worst patient the craziest one I think I've ever had was this patient was in labor and in delivering, and she felt and heard a pop. The whole room heard a pop.
Mm.
She came in and her pubic symphysis was separated over 2 inches. It
What?
just, yeah, it just tore the
Oh,
ligaments. Yeah, she came in a wheelchair. She could not walk. And
oh.
imagine she could not walk having a new baby, a newborn, and she was in a wheelchair. And so we were
Mm.
able to get her fixed and get her in a belt. And I said, don't get out of this belt. But you're just, there's so many more demands once you take that baby home. Baby's inside for pregnancy, you got stuff there. But when you deliver the baby, you can also have pain from that as well. And then then now you go home and now you're trying to take care of that baby and maybe a couple other kids, and you don't feel good because you are in pain. And so it helps everybody, everybody out when you
Yeah,
take care of your body. Yeah.
yeah. Correct me if I'm wrong, but now all of a sudden you lose the hormone relaxin, which relaxed all those joints, which made it easier to go out of joint, but also easier to go into joint. And now, if
Yes.
you go and you're outside of pregnancy, you no longer have relaxin. Sometimes I think it makes it a little more difficult to realign those joints. Am I wrong in
Absolutely.
saying that?
No, you are dead on accurate, because yeah, it's so much easier to move and when they've got that. But once delivery happens, and then it takes a few months, and as you're losing the relaxin hormones from your tissues, so there's some that's still residing in your tissues. And so by the time that gets moved out, you've got a window that's where it's so much easier to correct and get you in the right alignment, balance the muscles out, and then really start strengthening. And so that you can keep it in alignment. So yeah,
It's good.
you're right on.
I think we've done a disservice for our moms, and I'm going to throw dads in this as well. But car seats, I think car seats are actually getting fancier now. Most of them have like car seats with wheels, so you can, as soon as you take that baby out of the car from the car seat, you pop down the wheels and you push it. But I know that there's definitely a lot that you hook on one end, and sometimes if you've got twins, you've got them on both sides. But if you got it on one end, you're pushing out your hip joint. You're trying to balance this, maybe groceries in your right arm and baby in your left arm. There is a huge insult to the SI joint, I would imagine, and all these facets.
Yep. Absolutely. And then you look at the whole thing. You've taken 9 months to get to this size. You're growing this baby in you. And then all of a sudden, within minutes, that is gone. And now it's on the outside. So you've stretched out all your abdominal muscles. You've weakened them because they don't even remember what to do.
Yeah,
They've been accommodating that baby inside. So your abdominal muscles are just shot, and now your center of gravity changes again in a short period of time. And then now you've got the baby not inside, but now you've got it in those carriers, And I don't care how ergonomic they say that they make those, that they're just not. And you're
Yeah.
carrying, like you said, you're carrying one on one side and this on the other side. And you're doing that all with weakened muscles of the abdominals, the pelvic floor. If you had a vaginal delivery, you're dealing with so much weakness. And then you're now carrying more than you were carrying when before you had the baby, and you're carrying on the outside. And then that baby's only going to grow. So if you're actually doing your body and everyone a disservice when you don't learn how to take care of it and take care of it properly, because you've got to strengthen as you're carrying, as that baby gets bigger, you've got to be strong enough to be able to handle that and take and make that all work. Or you're going to then end up with more injuries, because if you didn't get it fixed, your pelvis is out of alignment, which is putting more stress on the spine. You bend over really funny, and that's a recipe for blowing out a disc. Just so many issues that then that's more like long term. Now you're dealing with a long term injury that's going to keep you down. It's going to make you miss work. It's going to just, and then miss your family on those activities your kid wants you to go
You're right.
play. And now,
Yeah.
you can't. So, it's life. We got to live it.
Let's talk a little bit about, you had mentioned something about those abdominal muscles are weakened and they have to accommodate a baby, which is just, I think, part of the process. How do you counsel patients or listeners to re-engage into appropriate exercise after having a baby? Are there guidelines that you give some of your patients that have some of these back pain issues?
Absolutely. We first really work with you to help teach you to find your deepest layer of abdominal muscles, which are your transversus abdominis. And they are the deepest layer of your abdominals. Those are really your true core muscles. And they're on the same layer as your pelvic floor muscles. And then they're part of the canister. So we look at the abdominals and that as a canister, and you've got your diaphragm on the top. So breathing correctly, and what from pregnancy, you're probably not breathing correctly, but learning how to rebreathe correctly, really trying to find those deep abdominal muscles again, find the pelvic floor muscles, and then activate the deep back muscles. That's really compromising your core. And because the one thing that would be advisable is to do that. And you've got to really activate those deep muscles first before you go and do 50 crunches or anything like that. Because when you're doing that, those
Mm.
are the external muscles. And that's fine at a certain time to activate those, but you've got to find and retrain the deep ones first, because they are truly your core. And anytime you go to lift, you should be engaging those. And most of the time you have a baby and you don't even know, you can't find them. So we're really re-educating people on how to find them, how to activate them. And the sequencing of the muscles is really important.
Can you give me an example of how you find those muscles? I'm
Yeah.
not sure if I understand that.
So I usually, especially if somebody's had a baby, I usually will get them on their hands and knees and try to have their back flat. And then and without moving the back, let your belly hang. And a lot of times the belly's already hanging. And then without moving your back, draw the belly button to the backbone. And just that act of movement, it's not a very big movement at all, but because gravity is you're again going against gravity right there, it helps you be able to find them easier. We can teach them on their back and stuff like that, but I like that way because it's very dramatic. And you can tell when your belly's sagging or when you've just pulled it in and pulled it taut. And then we're always guiding them through, helping them find it, because we have to reconnect the brain to the muscles as well, because it's a neuromuscular control, and that usually gets lost, or at least you haven't utilized it for 8 9 months, and so it really needs to be re-educated.
It's awesome.
Yeah.
That's great. Since my injury, and I had a spinal cord injury, and probably other listeners don't quite know that, but the therapist would always put me on my hands and knees, and it was like torture. I remember. Are we doing hands and knees today? 'Cause I think I may walk out of the therapy gym.
I'm just
There you
walking
go.
in on
That's
my
a
hands and my knees. And where they were probably wanting to activate your core, right? Or were they
yeah,
doing it for
yeah,
other reasons too? There's a lot of other reasons in your case.
yeah. And there's shoulder. I needed to get my
Hmm.
shoulder movement and stuff like that. So, yeah, that's
Yeah.
great. Let's go to the next topic. Have we covered everything we need to cover on SI joint? Do you feel like? Is there anything that we
I
should?
I think so. I think we've
Okay,
gotten pretty good into it.
sounds
Yeah.
great. How about we talk a little bit about, and the pelvic floor is going to be tough to talk about. How about we talk a little bit about the piriformis muscle? And this is a muscle that I think is so often overlooked from healthcare providers and everybody, and can be really life changing for people's pain. So let's talk a little bit about the presentation of this disease, of the pain of the piriformis muscle. Maybe talk about where it is first, and then let's talk about the presentation.
Okay. Awesome. From that sacrum, from that triangle shaped bone called the sacrum, the bottom part of the spine, there's a muscle on each side. And the piriformis muscle originates from the sacrum, from the sides of the sacrum. And then it goes right, traverses right across your butt and attaches to the out lateral aspect of your hips. It goes right across your butt. And on 60 to 70% of the people, the sciatic nerve is actually two nerves that run together in the same sheath. They kind of split just above your knee in the back, and one will continue down the back of your leg. The other one will come out on the side, and the nerves innervate muscles. There's more nerves than the sciatic nerves, but those are big ones. The sciatic nerve comes out underneath the piriformis muscle on 60 to 70% of the people. And so, that the proximity is right there, but on 30 to 40% of the people, one of those two nerves of the sciatic nerve actually pierces through the middle of that muscle, and then they join together underneath and then go down and do their same configuration. When that muscle's tight, that can actually pinch on the sciatic nerve or irritate it. And then you could have full blown sciatica. And that's where, and butt pain. There's so many people who will come in and go, my pain is right there in my butt. And that's a real thing. But the piriformis, so that I would say would be, you could have the piriformis syndrome. And but the piriformis muscle is also going to be involved anytime you have an SI joint dysfunction. That's the closest muscle. And so how we differentiate between, okay, is this a true piriformis syndrome, or is this dealing with the SI joint? And I always like to fix the low hanging fruit first, because, which to me is the SI joint. So we can fix that.
For
We
sure.
can fix that easy. We teach them how to do it. And then it's how they come back and how they present when they come back in. If they come back in and they're doing their pelvic corrections and they're really good on it, and we're seeing changes there and they're getting more stable, but they still have that pain in their butt, then we're going, okay, I think we're clearing up this over here, the SI joint dysfunction, but we may be dealing with a true piriformis syndrome. And that's just a little different approach. We treat it a lot similar and the same, and we're always going to treat the piriformis muscle when we treat the SI joint, but we want to see it responding. And when it doesn't respond, then we're more likely to have a true piriformis syndrome. And we can still treat that. It may require a few different things. When it comes down to that, and we've got it figured out like that, they may need injections to help it calm down and decrease the inflammation of the sciatic nerve. That's the biggest part of it, is just that muscle is so relentless on that nerve. And nerves don't like, as really well, nerves don't like to be messed with. They
Mm.
have their job, and they are electricity and they are fire. They have a job. They control the muscles. And so when the muscle gets a little cranky and it starts irritating it or pinching it or whatever, it's not a happy scenario in there. But we can do some dry needling with it too, some soft tissue work and stuff like that. So there's a lot we can do with it.
It's a tough muscle to reach. How are you reaching the piriformis muscle?
Knowing its origin and insertion, we can dry needle on either end of it, on both sides of it. We can do the medial aspect of the piriformis. So like with a dry needle, I'll go in, angle it
So you
toward
have them lay on their
on their
stomach.
stomach. Yeah. So they're on their
Okay.
stomach and I'm palpating, finding the muscle. And I look for, when I'm dry needling, I look for the trigger points as well. So I'm looking for those top bands of, and usually they're more painful, but you can really feel them. You're the master at finding those trigger points. We find them and we stick a needle in the first needle. If we're doing a medial piriformis, we're taking the needle right to the sacrum. And because we want to know the depth of the needle, we need to know the depth of the needle and where the sacrum is so that we can then pull it out and redirect it and then drop it right down to the side of the sacrum, right into that piriformis muscle. So that's how we find that. The lateral portion of it is pretty easy to find. It's just off the greater trochanter. But we don't want to get the needles in the middle because that's right where the big nerve is, and we don't want to poke that guy. It's already angry, so we're trying to reset the muscle. So when we do dry needling with that, we'll put electrical stim on the needle. So every place that needle is touching gets stimulated. And what that will do is really reset the receptors of the muscle, because when they get so tight, muscle fibers get really tight, that little receptor can go, oh, I guess this is our new normal, because we have receptors that sense where the fibers are in relationship to each other. And so when they get so tight for any length of time, then that little receptor goes, oh, I guess this is our new home, and it resets to that tightened position. So if we can go in there with some needles and some electrical stim, it's like pushing the reset button on a computer, and it releases the trigger point and it lets it go back. And that's one of the best ways that I've found to deal with that, because we can do some soft tissue work as well. But there you have to be a little careful, because anytime you're pushing down on the muscle, especially deep enough to get to the piriformis muscle, because it's under the glutes. So anytime you're pushing deep enough to get that, you're actually potentially putting a compressive force on the nerve, which is probably what it's already having, and it doesn't like that. So it can flare it up
Yeah.
really easily. So we have to assess, we don't know until we start working with the patient, like what their body's going to tolerate. So then we work with them. I'd probably start with some soft tissue work and see if we can loosen it up there after realigning the pelvis and getting what it's attached to in their proper position. And then we can see how they respond to that. And we may try different modalities to address that.
That's great. I have to tell you an interesting story about injecting the piriformis muscle when I was early on in my practice. I remember trying to find the trigger points within the piriformis muscle, and I would use a lidocaine bupivacaine combination. So a quick acting and a longer acting medicine, maybe 3 to 6 hours. And anyway, I injected the piriformis muscle and got the sciatic nerve. And so when the patient got up, she couldn't move her leg. And I was thinking, oh, what have I
Uh-oh.
done?
Oops.
And I said, I think you're going to be fine. It'll wear off in about 3 to 6 hours. So we put her in a wheelchair with a lot of assistance. And I called her later that night. How's your leg doing? Oh, it's good. It's come back. And I was like,
Yeah, that's
wow.
one of those that you just go, oh man, woo, we won.
We won.
Oh, yeah,
But it makes a big difference in these patients.
it
Huge
does.
difference.
Yeah. And
Big
again, it usually takes the collaborative effort, because what I do alone is not the whole answer. What you do alone is not the whole answer. It just takes teamwork with all of these
Yeah,
patients, especially the complex ones like the myofascial. And when they have those trigger points, it really takes the team. Yeah.
that's great. Let's talk a little bit about myofascial pain. How does that present to you? And what are the things that you're doing to make sure that we can really improve some of these trigger points, both functionally and maybe therapeutically?
That's a great question. There's myofascial pain is one of the highest reasons that people seek help treatment for pain. And I think there was a really good study, I've got it here somewhere, that showed that indicated that 85% of people in their lifetimes will have myofascial pain and will seek treatment for it. Now, in this population, it's a little bit different because usually we're now dealing more with the pelvis. So the myofascial can be anywhere in the body. But when people present with myofascial abdominal pain, it's usually chronic, and it's usually that they great presentation. And I always know when they come from you or from Howard Sharp, and it's like they will have seen 10 to 20 doctors, and usually more on
Mm,
the upper end of 15 to 20, like before they finally would get to you guys that actually understand and know what you're doing with pelvic pain. These people have gone around everywhere, and they're in pain, and they're just trying to find some help. And there's so many people that don't understand this area, which that's what's been is so awesome to work with you guys that really understand, because there's so many people suffering with it. But they'll present in the clinic usually with pain, and it may be worse on their cycle, but a lot of times they come in and they are now no longer working. They've got their whole life has been upended. They've probably had 2+ surgeries, and that's probably on the very conservative end because everybody's been trying to
sure.
find it. And what I find, and I'm sure you do as well, is that so many providers are either coming in with pain in your stomach, and everybody wants to know what's underneath and what's inside that could be there. Is your appendix rupturing? Is it whatever? And they're all looking inside, and they overlook this whole muscular system and the abdominals that is definitely a source of pain. And anytime you've got anything inside that could be inflaming the inside and hitting into the inside abdominal wall, you have a potential for pain and trigger points. I don't like endometriosis and any kind of bladder issues. If they're inflaming the inside abdominal wall or inflaming inside and they hit into the wall, then that can cause it. And I don't know if you remember this or not. I have to tell an awesome story, because your clinic, especially when your clinic was right above my clinic, it was so much fun because I could run up there and run by some things by you and ask you questions and work even closer together. But one time I had a kidney stone that it was just being a bugger. It wouldn't pass. It took like several weeks to pass, but it would move just a little bit, and it would sit there for about a week, and then it would move about a couple more inches and sit there for about, and it left all these trigger points along the way. And working with you, I was curious, what did those trigger point injections feel like? So I came upstairs, I'm like, Darren, I have all these trigger points to this little stupid kidney stone left. You inject me so I can see what it feels like. I don't know. For some reason, I think we were just seeing so many myofascial abdominal pain patients, but I'm like, I need to know what it feels like. So you did, and it was awesome. I don't know if you remember that, but that was
Yeah,
pretty cool. And
that's
yeah, but they oftentimes present with pain in their abdomen. And that's probably the most common one. And oftentimes their posture gets horrible because their only relief that they can get is by bending over. They're curling up, and they're curling up most of
mhm.
the time during the night, oftentimes during the day when these pain cycles, when the pain hits, if it's not all the time, when it hits, they're just doing that. So now you've got their postures forward, their spines getting all jacked up. And so that's what I'm seeing. There's how the approach to treating them is really, again, listening to their story and getting the pieces of the puzzle. If they've had a history of it, when did it start? How long's this been going on? What makes it worse? If we can, there's oftentimes, sometimes there's an insidious onset. They don't know what makes it worse. Oftentimes they will. And so we can just try to start putting the pieces of the puzzle together with that. And most of the time their pelvis is out of alignment, and their pain may have started with pregnancy and postpartum, and they never got it fixed. And now with their pelvis being out for so long, now they have myofascial pain in their abs, and it just is a whole other thing. Another thing I'm finding really a lot of is if they've had a C-section. If they've had a C-section or any other abdominal surgeries, they have scar tissue there. And so the scar tissue could adhere to the muscle underneath. And then every time you go to move, that pulls on the scar tissue, which then strains the muscles, causing the trigger point. So we see a ton of that.
What kind of landmark studies are there with dry needling, trigger point injections for treatments of myofascial pain? What do you have out there?
There's some really good studies. I've got a couple of them right here that I can get to you too, and you can put in the notes. But I think the one I liked the most was it's a comprehensive review of the treatment and management of myofascial pain syndrome by
Yeah.
Galasso and Urich. It was published in June of 2020. They found that most pain can be chronic. It affects up to 85% of people in their lifetimes. That's definitely not just working with the abs, but overall. And they say that it's really commonly overlooked as a component of the pain, just like we were talking about, is
Hmm.
like everybody wants to know what's underneath and you really not even seeing what the quality of the tissue is. But the effectiveness of, they have acupuncture is very effective, dry needling, and trigger point injections. Those are by far the top ones. Doing some myofascial release is very beneficial as well. So those are the top treatments that are
Therapeutic
beneficial.
options.
Yeah. Yeah.
That's great.
Yeah.
And I'll tell you what, these patients are happy. You change somebody's chronic pain to giving them relief, kind of resetting their systems, sure is an amazing, life-changing treatment. So thank you for being so
Absolutely.
committed to doing that. I know that you do that on a consistent basis, Cheryl.
You are welcome and thank you, because it's really nice to have people that you can collaborate with and understand and because so like I said, so many of these people just get passed around and go from doctor to doctor, and it's like when they finally end up with you, it's like, oh, you understand. And so they finally, now we can get a treatment plan and we can get,
Mm,
here's what we're going to do and let's see how your body responds. But they're not having to chase the pain and chase somebody, people that are just pass them on. Thank
yeah,
you.
yeah, you're welcome. Awesome. This has been amazing. Anything else you feel like you need to deliver as a message to these patients who may be suffering from low back pain, pelvic floor pain, abdominal pain?
Number one message is don't wait. Just, there's help out there. If you're going somewhere and it's not really changing, then keep looking, keep going, don't give up on yourself. Keep looking for, there are solutions to your pain, and just keep looking. But really, the sooner we can get this working on it and get a plan, the better. It just is so much easier to deal with earlier than later, because it most of the time, it just won't go away. And so now add on 20, 30 more years, and you've lost a lot of life, of your quality of life,
Mhm.
and missed out on a lot of activities because of that.
Yeah. And do it while you're pregnant. Do it while you're pregnant or
Yes,
soon after. Don't wait. Don't wait too long. And
absolutely.
this is not just the thing that you have to suffer about while being pregnant.
Yep, absolutely.
Yeah,
Absolutely.
huge. Okay, I'm going to ask you what I've asked all of my providers, which are the 5 things that you would never do as a clinician. So I know that you see things and you think, wow, I maybe it's all different for every clinician.
One, I would actually never give up on a patient. And
Wow.
that, ah,
That
sorry,
is true.
that makes me a little bit emotional, because I try to put myself in their position and would want somebody to not give up on me.
Mm,
So that's probably the biggest thing. I would want them to, oh, and we're doing what we don't want to. I just want them to walk away with hope, that there is hope, that they can have help. I would not, I would not ever listen to them. You've got to listen to your patients, because they have the most valuable information we can have as providers. And so that, I would never not listen to them and think that I know better. And that just is not the way it works. I would never, this is probably dealing with the, as a clinician, but also I'd never pass up a really cool rock when I'm out rock hounding and find it. So
that's so
that's
cool.
one thing I would just not do. And if you come to my house, there's a few rocks, right? Even the clinic, there's a few rocks there. And let's see, I have to go with Howard on No Country and Western Music. I got to back him up on that one.
Yeah.
Yeah, yeah. I'm
I'm a
not sure
country
what.
western
Yeah.
guy. I actually love
Oh,
country
do
western. That's
you?
so sad. Yeah,
No, that is sad. We can always change it, right?
that's okay. Fair.
We can always still get along.
This has been amazing. Thank you so much for your time, for your knowledge, for your concern for these patients who I think are really suffering. So I'm just going to say a few things that you can find us on Apple Podcasts, Spotify, Amazon Music, and YouTube at Not Your Doc Anymore. You can also find us on Instagram and TikTok at Not Your Doc Pod or Doc Watts _. Thank you for all those who have made this possible. Natalie Watts, the president and CEO of Not Your Doc Anymore, LLC. Our social media managers, Taylor Seberg, Emily Brown, Sarah Marion, and our production manager, Joshua Watts. We just need to clarify that the medical advice or procedural advice do not substitute for your own professional medical consultation. And I'm just going to add, you need to go to cutting edge physical therapy to get really a good comprehensive evaluation of your body. In addition, listeners or viewers need to be aware of the limitations of the information that we provided today generally.